Thank you all for those wonderful presentations. We've certainly learned some new and interesting and innovative approaches to addressing health literacy. We now have about 20 minutes for discussion, so if you'll just set your card up if you'd like to ask a question. Gail?
Thank you, Gail Matthey. Brandon, can you tell us a little bit about the reimbursement model? Like how are your services supported financially? Who are the payers?
For MedStar as an organization, ambulance services are a transport benefit under CMS, and so anytime we transport a patient to the ER, we would get reimbursed on that. Now, for the mobile integrated health care programs, the hospitals are paying us for the readmission avoidance program. Okay. We have several in Blue Cross Blue Shield, Amerigroup Medicaid are paying us for the high utilization group patients. And then we partner with home health agencies to intercept their patients when they call 911. And we also have a hospice revocation avoidance program. So for hospice patients that call 911 and potentially may revoke, we would intercept that call as well.
So you're making arrangements with all of these partners,
right,
so that they save money and you
right,
meet the needs of their patients more
absolutely
effectively.
Absolutely.
Thank you.
I can't see your name, but Jennifer.
Jennifer Dillahay with the Arkansas Department of Health. Some years ago, I read a book by Martin Seligman called Flourish. He's got a chapter in that book where he describes people with chronic conditions and that many of them suffer from a psychological condition called learned helplessness, where they don't attempt to help themselves even though they potentially could. And so I've been fascinated with this notion that improving health literacy could, in a sense, be an antidote for learned helplessness. And I thought maybe some of the things you described could be illustrative of that notion. And I wonder if you care to comment on that, whether you have found that or whether you've actually looked at this to see if there could be a correlation.
I think that's to everybody.
Yep.
Hi, I can say a little bit about that maybe. I'm not sure if this directly answers your question, but so I mentioned how one of the key sort of like interventions that our nurses and social workers use is brief behavioral activation or scheduling pleasant activities. So the idea is that like there's like this cycle of depression, right? So when people are feeling down, they have trouble activating themselves to do things that they like to do, and then they continue to feel down. Whereas if you could engage in an activity that you enjoyed, whether it was spending time with family, going to church, going for a walk, that you might feel better. And so I think that that process that they engage in with patients in terms of what's one thing that you can do today that might help yourself feel better, and helping the patient identify a goal for themselves in the next week or the next day or something like that, that's achievable, and then following up with them to say, how did that go? And if it went well, that's great, let's choose something else. And if it didn't go well, okay, let's talk about that and what can we do to pick something that's more attainable. Could maybe sort of like play into what you're talking about. So oftentimes our patients might choose a goal like, oh, I really want to like run a 5K, right, in a month, but maybe they have not even like walked a block in several years. And so you might say to them, okay, like that's a really good goal. What's something that you could do in the next week? Oh, I'm gonna like look for my sneakers and find them. And then if you can make them successful at that, or if they can make themselves, right, if they achieve that goal and you follow up with them and have a great follow-up conversation with them about it, then they have felt successful, and maybe some of that like helplessness goes away because they feel like they achieved a goal that they set out to, and that like helps them achieve their long-term goal of running the 5K.
As far as the patients that we see in the programs that we've implemented, you know, at first we may be there to hold their hand and, you know, assist them with their healthcare and assist them with navigating. But the end goal is for them to be independent by the time they graduate. So for the example I gave of that lady that had so many medications, I saw her again last week, and I went to her house. She opened the door, and she's like, "I have a surprise for you." And I was like, "Oh, you do?" She's like, "I filled my pill box," and I was like, "Uh-oh, uh-oh." But she had used the previous day as a template, or the following day as a template, and just was able to identify the pills and where they get, and she did it correctly.
Ernestine?
Thank you. I appreciate all of your programs and how they have demonstrated some outcomes that will improve healthcare. But as I was sitting here thinking and reflecting on, we all create these different programs, and we also, I'm not sure I could hear from either of you, whether it's the Bridge program. Jessica and Brandon, I really want to know specifically about your program, of how that information got back to their home, medical home, or primary care, such that is that exchange of information benefiting in an ongoing way, such that providers know more about their patients, because all of you all tend to identify social determinants of health, and those social determinants of health influences health. So I'd love to hear how that information, such that you improving the health literacy of the organization is providing care.
Good question. And I want to say that we're very much in the process of building our mental health bridges intervention, which we're framing as a health literacy intervention, basically, in an online space. And so we're doing very much what Brandon talked about in terms of developing tasks and activities scaffolded so that by the time the user, participates in the online intervention, they will develop a plan with respect to their particular health question and take the plan to their healthcare provider. That we are not yet finished building, but I'd love to share positive outcomes with you when they happen.
And for our patients, we are in constant communication with the outpatient case managers. That's for all of our referral sources. And all of our documentation, it gets faxed to the referral source. It gets faxed to the primary care doctor as well. And for our largest referral source is the county hospital. And so all of our documentation is uploaded into Epic. And so that's accessible by the inpatient physicians, the ED physicians, and the primary care physicians.
Quickly answer. So because our program is embedded in primary care, so ideally, and this is not true for all of our sites due to space constraints, but ideally the nurse or social worker is physically located in the primary care clinic and has a good relationship with the primary care providers. And at our different sites, the different facilities, the way they communicate really varies. So they always document in the medical record what happened with the patient, including the psychiatric consultation. So if the patient was discussed with the psychiatrist, then either the social worker or nurse, or in some cases the psychiatrist themselves, will document what was discussed and what recommendation was made to the PCP. Sometimes, especially in our smaller clinics, they might seek out the PCP, the social worker or nurse, in addition to that, to say, hey, we talked about your patient, they recommended this medication or titrating the med up or something like that, so that they have that like face-to-face interaction. Some places they use email also as like an extra check. So it really just depends. They figure out how their PCPs want to communicate with them. The other key thing that we have is we have a champion PCP who sits in on the weekly case consultation meetings, because not all of our primary care providers can participate in those, right? We have so many, but that person is really important in terms of like bringing general information back to the patient's primary care provider, and if there's a specific issue, then they might be able to better like seek them out to tell them.
I'll follow up with yours, Jessica, the schools. Because I know New York's school system have a good mental health component. So how does the school information mental health get back to the primary care medical home?
I don't have the knowledge to speak to that. So we don't have collaborative care at any of our school-based health centers yet, although I'm hoping to this year. But I do know, just anecdotally from speaking to our school-based health center staff that they use the same medical record as the hospitals do.
Larry?
Hi. Larry Smith. This time I'm going to talk from Northwell Health. So we have a fairly extensive program of embedding behavioral health workers in primary care offices that are both amenable and large enough on a scale. What I'm intrigued with is that you're using RNs. So we are using people who are either social workers who are trained in psychiatric counseling or behavioral health nurse practitioners, which are far more costly than RNs. So what I'd like to know is, since just talking to people doesn't have any proof that it benefits depression, I mean, specific therapeutic interventions do, how do you train these RNs and how do you monitor that they're not off doing their own thing as opposed to actually delivering the specific type of therapy you want?
That's a really good question. So I will say that because in some of our programs we have RNs and in some cases we have LCSWs, there is a wide range in knowledge and experience in terms of like what the patient is receiving. For collaborative care, there have been some studies even in developing countries where they trained lay people to deliver an intervention for depression, most often using motivational interviewing and behavioral activation. So it is and shown to have effective results. So it is possible to do that. One of the reasons why they chose to train nurses at health and hospitals, and I wasn't there when they decided to do that in 2013, 2014, is because they were really focused on the comorbidities between chronic disease and depression. And so they wanted, again, in making it easy for the patient, to have them be able to work with one person on both their chronic disease and their depression, so that they could meet with the nurse and talk about diabetes education and hypertension control, and then they could also address the depression. So what we do is, like, let's say we have a new nurse who's assigned to the program. On my team, I have what we call collaborative care clinical coaches. They're usually, or they are people with clinical background, so either nurses or social workers, and they're sort of our like boots on the ground. They're in the facilities. They're assigned to several sites, and they work really closely with our nurses and social workers, providing training and in the moment coaching. So in the beginning, they'll provide some training, and then they'll observe them with patients. They'll give feedback, stuff like that. And we, try our best to provide ongoing training as well. We provide training to our nurse educators who are there, all the time. And we have found, in looking at our patients' outcomes, that there's really no variation actually between outcomes for patients who are working with a social worker and outcomes for patients who are working with a nurse. I will say that it takes a special kind of nurse, even special kind of social worker, to do this work. It doesn't work for everybody. So we do have high turnover in those roles. For the people who want to do it and are interested, they stay and they're really good at it.
And just to follow up, the psychiatrists, are they a consultant to these nurses and social workers or to the primary care physician of that patient who's in the office overseeing the whole thing?
Yeah, so both. So the most formal way that consultation occurs is in a weekly, like a scheduled case meeting where the nurse and social worker are there and the psychiatrist and then the champion PCP. And so they discuss patients who are new to the program and patients who've been enrolled for a certain period of time, 70 days, and are not improving as you would expect. Then oftentimes the nurse or social worker relays the information back to the PCP, but the psychiatrist is hopefully like a familiar face to the PCP. They're somebody who is in the same hospital or in the same clinic, so they can reach out to them and ask them any follow-up questions or stuff like that. And we're working on ways to do that electronically now as well, so that they can sort of engage in it back and forth in the medical record.
And who writes the orders for the medications when they're used?
The primary care physician.
Okay.
Always. So that was a big challenge when we first started. So, 5 years ago, our PCPs were not very excited about writing depression prescriptions. It took a lot of hand-holding from the psychiatrist to be able to do that. But I think having the psychiatrist available has been a really tremendous help. I would say now I hear very little about PCPs not wanting to prescribe a depression medication. I think titrating can sometimes be a challenge because they want to start at really low doses. But I would say their comfort level now is really high. We expanded this year to anxiety. And people got really nervous, right, about benzos. And so we're doing some education to our PCPs about that and using SSRIs, which they're familiar with. But yeah, there's definitely a learning curve, and having the psychiatrist available is really important and helpful.
Next to Larry. I can't see your name.
This is Ellen Markman. I have a question for Albert. I have two closely related questions. One is it seems as if you're providing evidence that for people with depression who are getting on these blogs or social media, having conversations, that on a number of different topics for those conversations, you're seeing results and improvement. The one that looked like it wasn't showing improvement was positive topics. And then my larger question is, you talked about depression being contagious, and that interacting in general is thought to be not particularly beneficial. So how do you reconcile your results?
Let me start with the second question. So second question, there are two different ideas. One's interacting with other depressed individual is not particularly good for your emotional states, and at the same time, those communities were formed to help and provide emotional support, and just being around people, socializing people, and belonging to a group is, I think, contributing to the improvement in their individuals in their emotional states. And for the first question, I think we didn't see any improvement for the positive group because they started out with such a high level. Like, they all started out with the positive emotion. They didn't have room to improve, whereas depressed individual, they have more room to improve. Thank you.
Along that same line, I had a question, which was, does anyone oversee or interject in those communities? And if so, do they try to steer it in a positive direction?
So for Reddit, it depends. I guess the accurate answer is depending on the group. For Reddit, there is a moderator, but because there are so many different, or so much like participation, you can't really moderate everything that's being posted. So there is I do see some evidence that where I guess like harmful contents being removed, but at the same time, some of them are still there, and sometimes the community themselves are moderating. They're like notifying and telling this is not what we do here, type of deal. So they're both ways, and yeah, I think it's self-sufficient. So that's why community continue to exist and grow. Thank you.
Yanka Shiobala, University of Wisconsin-Madison. Yanka Shiobala, University of Wisconsin-Madison, School of Pharmacy. I have a question for Dr. Park. You did talk about the fact that at the end of your findings, people in the individuals who had depression in the online community eventually became happy, but then the use of words such as related to death was still sort of prevalent. I'm just wondering, now, do you sort of reconcile that they became happy, but at the same time they were still using a lot of the swear words and death? And also a follow-up question also is there an opportunity to be able to take some of that information and direct people to referral services, especially to prevent a potential suicide, for example?
So the first question about death and the negative emotions, or terms that are associated with negative emotion, I didn't mention this, but that was actually negative correlation. So they were using less and less those words. They're talking about death less and less. So that's how we categorize as improving for negative connotation words, and positive connotation words they're using more and more. So those are I didn't go into detail, but so and what was your second question?
My second question is there an opportunity to, who monitors those conversations to prevent a potential suicide because of, the possible correlation?
That's actually a really good question and a difficult question to answer, because let's say there's 100 positive case and 1 negative case. Everyone's going to focus on the negative case. And that's because of that, it's hard to recommend something when it's not quote unquote proven method. So I don't know if we can steer individuals suffering from behavior disorder to that, but it can be recommended because there are positive, some evidence showing positive results. But I'm not sure about suicide ideation or anything related to that. Not yet, anyway.
So we're at time. So if your question is very short, okay.
Hi, Chris Desi, Bristol Myers Squibb. Albert, I appreciate your work, and I'm trying to think of what it means. And my understanding of depression is that it's up and down, and I'm not sure that those people who end up happy are sailing off into the sunset of happiness. Is it possible that this study, if designed at the happy point, it will show a correlation that it goes into negative? You understand my point?
So I think that question has a two-part answer, actually. I think that's a really good question. So instead of going to see your psychiatrist and take the DSM-9 test, if we use something like social media where you're constantly engaging, you can monitor your emotional changes throughout the day, your ups and downs. So I think there's a benefit of that. And at the same time, I think there's a little bit of what you're saying when you start out high, like positive emotion, it's going to be hard to. So there's going to be a little bit of bias, but at the same time, such a large data set, I think a lot of those cases can be removed, and that's going to be same for a lot of different communities, I think.
Melissa reminded me that I'm just eating into my time. So mine is more of a question or a comment than a question. But I think in a group of communication experts, one of the questions that we have is also the other side as providers. Is there any discussion that we should be having at some point about whether we should be recommending people to participate in online communities for their activities, and what is the sort of safe zone for that, and how do then providers join in or step out, or what are the boundaries of communications that are increasingly happening outside the offices and outside the communities in the vans and in an online forum where it may or may not be moderated. And I think it's way too much to talk about now, but just on the record, I think we should be talking about that.
Thank you.
Thank you very much, Teresa. And thank you to the panel. I think we'll take a 15-minute break and come back for the next discussion with Katina. Thank you.